apologize. I'm starting to lose my voice, so I will do the best that I can with this. Once again, I have no relevant disclosures. So it's not a surprise to any of us that angiogenesis is an important part of cancer overall. If you can't make new blood vessels, you can't make a tumor. Once again, the obligatory pathway slide. So this is very complicated, and over the years, a huge slew of agents have been looked at to try and combat angiogenesis. And really, VEGF and VEGFR inhibitors have been the most successful in lung cancer, and that's what we're going to focus on. So agents that target the VEGFR pathway can do it from the outside with antibodies and from the inside with TKIs, and we'll talk about a little bit of both of those. And remember what I said earlier, that repetition is learning. So you're going to see a lot of repetition this morning. I'll thank my colleagues for introducing many of these things already. So bevacizumab with chemotherapy, we don't need to talk about 4599 again. It was discussed yesterday and again today, but this is the first trial that broke this historical benchmark of 12-month survival in a significant benefit with the adenocarcinoma histology, with a 4-month increase in overall survival, which is huge at the time and is still pretty big. A number of exploratory prognostic factors have been looked at to see if we could select the patients who would do better, looking at sex, the development of hypertension, whether adhesion molecules are present at baseline, what the VEGF levels are, and what happens to E-selectin after a few weeks of therapy. And there's a smattering of suggestion here, but none of these have turned into a usable clinical biomarker yet. And when different chemotherapy was used with bevacizumab, we didn't see an overall survival advantage. And I'm sorry, my colors seem to have switched themselves, but since the survivals are all the same, I don't think it matters much. There was a meta-analysis which was published by Jean-Charles Soria a couple of years ago, looking at 4 phase 2 and 3 trials. Here they are. 2,000 patients. The overall survival was improved, but it's statistically significant, but look at that hazard ratio. So it's not a huge difference. PFS does better than overall survival. Adenocarcinomas do best overall, and patients who are pretty healthy, as measured in this analysis, by less than 5% weight loss. And again, we see that about 4-month survival difference, with a pooled analysis showing an overall survival. So what about looking at bevacizumab with chemotherapy and then bev and pem maintenance? I don't need to go through these very quickly, very detailed, because you've just seen them thanks to Tracy. Looking at avapril, where the previously untreated patients were treated with bev, pem, and cis with a maintenance of bev, pem versus bev alone, and looking at Point Break, which was comparing the 2 different regimens, carbo-pem and carbo-pac, with bev, and then bev maintenance with pem versus bev alone. And looking at the survival curves, there is an improvement in progression-free survival in the group that was looked at since randomization, and in the group that was looked at since induction. So this is the group from maintenance, and this is the group from induction. But you see that those progression-free survivals are greater than the overall survival differences. And in the Point Break trial, in the intent to treat population, and in the maintenance population, the progression-free survivals seen here, and so I won't belabor those points since they've been discussed already. And again, you can see that the overall survivals are very close to the same. What about if you add bev to a targeted therapy? This has been done in both unselected and selected patients. The unselected patients were done obviously earlier. The so-called beta trial took bevacizumab with erlotinib versus erlotinib alone. And in that group, the addition of bevacizumab to erlotinib in these unselected patients did not improve survival. The Atlas trial, there's the not improved survival. The Atlas trial did essentially the converse of that. They took patients who were on bevacizumab with or without erlotinib and had a progression-free survival advantage, but not an overall survival advantage, again in this unselected patient population. And the biomarker analysis, which I apologize, my highlight has crossed out my biomarkers, but suggested that patients with KRAS wild type or EGF receptor mutation positive non-small cell had the best overall benefit, and perhaps that was a reflection of patients who may have had EGFR mutations in this unselected patient population. So in the selected population, Greg has already shown you these data for a combination of erlotinib alone or with bevacizumab in the Japanese trial, which has now been published in Lancet Oncology. The primary endpoint of this trial was progression-free survival, but there was independent review, which is important when assessing these things. And the median progression-free survival, as you've already seen this morning in the combination arm, was 16 months in this upfront mutant-selected patient population with the combination compared to 9.7 months with erlotinib alone. So this is encouraging in a phase 2 randomized trial and certainly warrants further analysis. However, looking at all of these combinations that have been looked at and looking for an overall survival advantage in an unselected patient population, you're seeing that that is still sitting just with bevacizumab and PAC-carbo. The ECOG 5508 trial is ongoing, as Tracy's just shown you, and so we'll wait to see what the results of this is. And I think this is going to be the really important distinction, because many people think in the unselected patient population that what's making the difference there may be more the PEM than the BEV. What about adjuvant bevacizumab in resected non-small cell? Now I finally get to tell you something that you haven't seen already today and yesterday. So Heather Wakely presented these data at the World Lung a couple of months ago, the highly anticipated results of ECOG 1505. To remind you, patients in ECOG 1505 had resected disease, stage 1B through 3A. They were treated in a narrow window postoperatively, 6 to 12 weeks, stratified by the type of adjuvant chemotherapy they received, the stage, the histology, and their gender, and randomized to chemotherapy by itself. Here are the chemotherapy regimens, and chemotherapy with bevacizumab for a year. So patients had to have had complete resection. They had to have had decent nodal sampling, going back to what Dr. Pass told you yesterday. They had to have been within the 6 to 12 weeks post-op, an excellent performance status. They could be on anticoagulants, and they could have squamous histology because their tumors, which were likely to bleed, had been resected. They can't have had any previous chemotherapy. They can't have other cancers. They can't be clotting or having TIAs or strokes. They can't have uncontrolled hypertension at a baseline, obviously no hemoptysis, and no planned postoperative radiation therapy. The primary endpoint was overall survival. The patients were accrued in about a 6-year period of time, 1,500 patients. I would argue that this is very good accrual for a lung cancer trial. The 6th of the many planned interim analyses in early 2015 suggested at that point, 41 months of follow-up, that the trial results be released, sadly due to futility. 15% of patients who went on were ineligible for various reasons, and 2% never started therapy. Sorry. The patient demographics are seen here and are well balanced, and actually the chemotherapy is better balanced than I would have thought across the 4 regimens. And we see that in the squamous histology that was present in about 28 or so patients averaged across the 2 arms. Most of the patients had lobectomies, about 75%, and everybody had very good mediastinal node sampling seen here. But notice that a quarter of these patients had N2 positive, so these were stage 3 diseases. The toxicity is what you would have expected. They generally were a little bit worse in neutropenia and hypertension, which you would expect with BEV, but no significant differences in fatal adverse events. And here are the overall and disease-free survival curves, which are clearly completely superimposable. So the authors concluded that the addition of bevacizumab to adjuvant chemotherapy did not improve survival for patients with resected early-stage disease. So what do we know about bevacizumab? Well, obviously angiogenesis is important, VEGF is an important target, but we're still not quite selecting the best patients, in my opinion. We don't have good biomarkers to tell us at the beginning who would do the best, and only 4599 has shown an overall survival benefit, which I think is concerning to some degree despite the meta-analysis. And the benefit's relatively small for most patients, but there clearly are subsets of patients who have significant benefit, and we need to do better at sorting those out. The expense is a concern, toxicity of long-term agent is also a concern, and maybe there are other anti-angiogenics that would do better, but we don't know how to select patients for the best targets yet. So talking about Revel, which was presented at ASCO last year, a different drug, ramucirumab, which is a VEGFR2 monoclonal antibody. This is a human IgG1 monoclonal, which is specific to the extracellular domain of VEGFR2. 2 phase 3 studies in second-line gastric cancer that you heard about from Dr. Putness yesterday told us that this was good therapy in patients with gastric and gastroesophageal cancer. And the Revel study looked at this in lung cancer, stage 4 non-small cell lung cancer, 1 platinum-based chemotherapy with or without maintenance. They did allow a prior BEV. All histologies were allowed, and again, excellent performance status. The stratification factors are seen here, and patients are randomized to standard second-line docetaxel with placebo versus with ramucirumab with treatment until progression or toxicity. The demographics were well matched. The response rates were low for CRs, as you would expect in the second-line setting, but the overall response rate was 22.9 for the RAM arm and 13.6 for the placebo arm, statistically significant, as was the disease control rate, which was about 10-ish percentage points better with the addition of the ramucirumab. And here are the progression-free survival curves with a PFS of 4.5 versus 3 months. And here are the overall survival curves with an overall survival of 10.5 versus 9.1 months. So this is statistically significant. How clinically significant it is, I'm not entirely sure. And this, at least in my part of the world, hasn't really penetrated much into practice in the second line. By histology, you see that the curves for non-squamous and squamous histologies are seen here. And in terms of safety, the vast majority of patients had at least a grade 3 adverse event, but it wasn't really much different between the placebo and the ramucirumab arm. Drug-related, perhaps a little bit different numerically. Neutropenia, febrile neutropenia, thrombocytopenia are important toxicities, a little bit worse, but again, numerically worse. Stomatitis and mucosal inflammation, again, but mostly grade 1 and 2, and some peripheral edema, a little bit more in the early grades 1 and 2 in the combination arm. AEs of special interest, so are these patients going to bleed? There was some increase in bleeding, but it was primarily epistaxis, so not of great clinical significance. And the authors concluded that the primary endpoint of overall survival improvement was met, that there was statistically significant improvement in PFS and overall survival, and that they were consistent in all of the major subgroups, including squamous and non-squamous histologies, with no significant increase in bad AEs and no significant increase in AEs leading to death. Safety profile is what you would have expected, and so this was the first publication of a novel agent with standard chemotherapy in second-line patients. What about other strategies? TKIs, we'll look at nintedanib. Nintedanib with or without docetaxel, docetaxel with or without nintedanib in the second-line setting. This was a late-breaking abstract at ASCO a couple of years ago. I've also included, just for your information, the publication so that you have the reference there in Lancet Oncology from last year. So this is a TKI. It's oral. It's much more promiscuous. It inhibits both VEGF, FGF, PDGF, RET, and seems not to have too much problem with the CYP system, which is one of the problems for some of these agents. The safety profile in combination with chemotherapy in previous studies had not been alarming, nor in combination with afatinib, and so single-agent nintedanib was felt to be active in a phase 2 trial, which merited going on to this phase 3 trial, the LumiLung-1, which you've already heard some about this morning. So in this trial, patients were randomized to standard second-line docetaxel versus docetaxel with nintedanib, again, placebo-controlled, excellent performance status. Prior BEV was allowed, so there's a stratification for yes or no. Histology, both squamous and non-squamous, were allowed. Brain metastases were allowed, and this was a stratification. So here's the primary endpoint of progression-free survival, and you can see 3.4 versus 2.7 months. This is highly statistically significant, but one could argue whether a less than a month difference in survival is clinically significant. There was independent central review for the PFS endpoint, and you can see adeno and squamous carcinomas reported separately here. And here's the overall survival in all patients, which is approximately 1 month different and not statistically significant. In adenocarcinoma histologies, 10 versus 12. So that's a survival difference that we find acceptable in lung cancer to say something may be useful, and you can see the curves here. And in squamous histology, the overall survival was not different. Safety was reasonable. There was not, again, because this is a second-line chemotherapy trial, most patients had some degree of adverse events, but no significant difference and nothing that seemed alarming. So the authors felt that LumiLung-1 showed that it had met its primary endpoint, that nintedanib did significantly prolong PFS, regardless of histology, that there was an improvement in overall survival in adenocarcinoma patients, and that there was a manageable safety profile. Now, this is actually approved in the EU for use in non-small cell lung cancer. In the United States, the approval for this drug is in idiopathic pulmonary fibrosis and not in lung cancer. And I don't know that there's any change in that on the horizon anytime soon. There has been a meta-analysis of the TKIs. I didn't present all of these data because there isn't much difference in overall survival in most of them, but I do refer you to the meta-analysis, which looked at 20 randomized controlled trials, so this is a very useful review. There was an increase in response rate and progression-free survival overall, but no increase in disease control rate and in overall survival. So there are a lot of things that we still don't know. We don't know what the optimal dose and schedule of bevacizumab is, in my opinion. We don't know what the benefit is beyond disease progression. We don't know what the best chemotherapy partners or biologics are. We don't know exactly how to pick the patients that will do the best, and we don't know how to use the TKIs the best. So how can the promise of anti-angiogenesis be realized? Well, we need more studies. We need prospective, well-designed trials. We need a lot of correlates. We need to pay for this with a collaboration between pharma and academics. We need to do bucket trials so that we can put combinations together quickly and efficiently. We need to make the trials system more available to patients and their physicians so that we get more than the 2 to 3% of non-small cell lung cancer patients on trials than we do now. And that will require a revamping of the clinical trials system. It requires revamping of the consent process, which the NCI is working on again. Corey and I were around when the NCI worked on the consent process last time, which was, 20 years ago or something. We need to revamp the way that we collaborate with academia and pharma. We need to make things a lot simpler. In my view, we need to do something urgently about the multiplication of CROs that have arisen in this country to make things better. So see, Corey, I had 3 minutes left, so it was my political statement for the day. So we need to make it so that all of our patients, because a minority of them are seen in big academic centers like the presenters at this conference have come from, and most of them are seen out in the community. We need to make these trials relevant and available and easy to manage for all patients, because if we can get the same number of lung cancer patients on clinical trials that we get pediatric patients on clinical trials, we will make rapid progress and make things better for everybody. And with that, my political soapbox is at an end.